And we'll jump right in. Here we go for meeting is reported. So the biggest one is, and I suspect most of you who are on have probably heard this, but we're revising the launch date. That will be January 1st, 2025. So we're pushing it back. It had been September 1st. We've had a lot of really helpful comments from many of you, and we've appreciated that engagement, and it's helped raise several, I think, important questions that we are internally still discussing. And so some of those things we won't necessarily have answers for today, but we will be looking to provide responses to or answers for in the future. So thank you for those questions. We look forward to hearing more from you today, and looking forward to further discussion. So again, launch of the program is delayed until January 1st of 2025, allowing us for further engagement with all of you and other stakeholders to make sure that we've answered questions and people feel comfortable with having their questions answered and ready for the launch. They can go to the next slide. So this is kind of where we are. So what we've recently done, you'll see on the left, these are things recently accomplished or that we've done to date. We've done actuarial modeling and program testing. Draft case rates have previously been provided. There's been some performance reports as well that providers have received. And there's some video guides and FAQs that are out. Currently, we're working on, in the middle here, additional considerations of program refinement. So based on some of the comments we've heard from you, as well as conversations that we're finalizing with CMS, there's billing guidance and updated FAQ that will be forthcoming, as well as a quality measure reference guide that you all will have access to. And then upcoming will be additional provider bulletins that include payment policy and processes, and then final performance year case rates, and then performance year provider reports. Thanks, Kim. I see included here that under the click more, and then the Q&A function is underneath that. So apologies if everyone else could see it and I couldn't, but the Q&A function is there if people want to post them that. And just as a reminder, the DSS has a website with updated materials that is posted. You'll see it linked in here, but if you just search for CT DSS maternity bundle, you'll quickly also be able to find it. So in case you didn't link this, so just keep in mind it's readily available. We want people to use that as a resource. Next slide. And I think, be passing it off now to Tiffany, who will walk through a few other things. Again, a few other things to walk through, and then we'll be opening up for questions. So Tiffany, anything I missed at the top there?
No, I think you covered it, so I can take it from here.
Thanks, Tiffany.
Great. So as Brad mentioned, in an effort to be as responsive as possible to some of the questions we've received, DSS had previously shared draft case rates based on the actuarial modeling and program testing for 2022 claims. In response to provider requests, we're sharing additional information for around the case rates development so providers can better understand how were the rates developed, and also how a little bit more insight into what future revenue under this new model might look like. So as a reminder, each of the rates are based on each practice's historic utilization, so taking into account your previous service mix. And then from there, these rates are based on deliveries that were incurred during the dry run or actuarial testing period, which is October 1st, 2021 through September 30th, 2022. As a reminder, these rates will be refreshed during go live, so those rates will be shared closer to January 1st. So we can dive into the specific details around how the rates were developed. Getting into that, I'll just take us through this table and walk us through the definitions, and I can pause for any questions. So in this table here, and this letter was provided through CHN provider engagement service reps just last week. So this is fresh off the press. But our first column here, we have attributed episodes. This is going to be the number of episodes that the accountable provider at the TIN level is responsible for, specifically in this historic dry run period. Then we get into the second column. This is the first trimester fee-for-service payments. This is the total payment for all services that were provided in the first trimester. As a reminder, all services in that first trimester period are going to be not included in the case rate, and they're therefore paid for through fee-for-service. Then we get into the case rate development details. Here, the way DSS calculates the case rates is they're going to review claim history from the second, third trimester, as well as the delivery if performed by the accountable provider practice, and the postpartum period for all births that were attributed to them. So looking at all of the attributed episodes, they're going to summarize the claim experience into the total payment and divide that by the average months of payment per the case to come up with the draft case rate. So here we see, just to clarify, we see the total payment for maternity services. And this could include payment based on fee-for-service or based on case rate. And that's going to be divided by the average number of months of payment per case. And this is based on your historic experience. I'll point out that if providers were to trigger the case rate at the start of the second trimester, you would be eligible for around 9 months of case rate payment. So this is where there may be opportunity to earn more payment in the program year than what you've historically seen by seeing patients earlier and submitting claims with the trigger event criteria to get the case rate started relatively early. And then we have the draft case rate. That's going to be the monthly provider-specific case rate based on all those details that I just mentioned. And we can go into the next slide to talk about some of the trigger event criteria that enables practices to start and initiate this payment. So just wanted to provide a reminder about the trigger event criteria. Practices are able to start billing and receiving the case rate if they meet the trigger event criteria beginning in the second trimester. And to do that, you need to meet a couple different things. So the first one is the practice has to perform at least 30 or more deliveries annually. This is pretty standard. If you're going to be participating in this program, you don't have to worry about meeting this criteria. It's going to be applied to you automatically. From there, when you're submitting claims, you're going to need to submit a trigger diagnosis code. The code list is published on the DSS website. There's also specific E&M codes that need to be billed, and then it needs to be billed with a qualifying place of service, which is 11, 19, and 22. I'll just highlight at the last provider forum, there were some questions around the place of service criteria. So I just wanted to highlight that this is an updated decision that DSS has made with the goal of being able to appropriately identify attribution changes between different providers in the various settings. And then there are specific maternity bundle specialty types that also need to be billed: OBGYN, including the subspecialty MFM providers, family medicine, certified nurse midwife, obstetric nurse practitioner, family medicine nurse practitioner, women's health nurse practitioner. We will also know we've received additional questions around global billing guidance. So we do recognize that for practices who don't currently bill using these criteria, that would represent a change in billing practices. The key reason that we're moving away from global billing is because global billing tends to be contingent upon meeting fee-for-service requirements. And through this program and the payment model, we're trying to move towards prospective payment to enable more flexibility in the care that you're able to provide and in allowing more care coordination within your practice. We will note that more information is coming to be clear about how to enable trigger event criteria and make sure if there is a change in your billing practice to provide additional guidance there. At this moment, DSS is recommending that practices bill to meet the trigger event criteria when possible to ensure that you're able to maintain episode attribution. And like I said, additional guidance is coming. We particularly heard questions around how to bill and proceed with global billing for members who have Medicaid as the secondary insurance. So we will definitely be following up and we hear those questions. And real quick, just to wrap up, like Brad mentioned, we are working very actively to provide up-to-date information for the practices and for you guys. So that is forthcoming in the next couple of weeks, aiming to get out an updated FAQ, some specific billing examples so you could see how the case rate might play out in different scenarios, and just more billing guidance around billing and payment processes. As we continue to work with you guys and get this program ready for go live, we'll also continue to hold additional provider forums to be able to listen and hear your feedback. So I will open it up to questions now. I see a couple in the chat. I'll also mention before I close off that we do have, like Brad mentioned, the DSS website with a plethora of different resources, more to come, more to be added. So we can go to questions. The first one I see, what will be the data range used to calculate the case rates for go live? Grace, do you want to answer this one?
Yeah, so we are, sorry, maybe the date will be shifted a little bit, but basically we're going to look at 1 year forward. So as Tiffany was saying, the study period or the dry run period we're using to create the first sort of dry run case rates was for deliveries happened from 10/1/2021 to 9/30/2022. And then for the actual case rate development, we'll use 1 year after. So 10/1/2022 to 9/30/2023. So 1 year worth of delivery. So basically what that means is that we're going to identify the delivery incurred during that 1 year. And for each case, we're going to look at the starting point of the second trimester to the end of 90-day postpartum. So every case has a very sort of curated period of 270 days that we're going to study to develop this case rate. But overall, the criteria is that the delivery needs to happen between 10/1/22 and 9/30/23.
All right, the next question, will the monthly payment be paid to groups even if they don't bill monthly visits during global code case rate?
So I can definitely feel free to jump in if anyone has anything else, but the understanding is that global code will not trigger a case rate, meaning let's say if this a member comes and then the provider decide to only bill global code for the entirety of the services from second trimester to the postpartum, there's nothing else billed. Just an example. What that means is that eventually you will still get reimbursed fee for service for that global code claim per claim in this history that the system can identify to trigger the case rate starts. So, but if let's say in another example where there's global code, but there's also in the second trimester there is a claim with E&M code with the one of the trigger code, and then all the right criteria, meaning that case is identified to associate with a provider, then the case rate will start from that month all the way until the end of the postpartum. So it really depends, but just to note, if the case rate does trigger, hence the months of case rate payment will happen, then that global code will be zeroed out. So they won't be paid fee for service, versus if there's no trigger, it will just be paid per usual as fee for service.
And just to kind of reiterate, Grace, what you said, I think I saw the follow-up question was just, do you have to bill monthly claims to receive the monthly payment? Once as Grace kind of said, but once it's been triggered, so once there has been a trigger code with a correct diagnosis, that case rate begins and will continue on without the need. The exception to that is if there's a change in providers, or if there's multiple providers that are both receiving the case rate, then there would need to be a reestablishment of that case rate on a basis. So for example, I'm the primary OB. Grace is the maternal fetal medicine provider. We're under separate TINs, for example, in this case. So let's say where there's two different tax ID numbers. I refer, this is second trimester. I see the member in the office. I bill an E&M visit with a trigger code. That starts the case rate. I identify them as high risk for some and having some MFM need. I refer them to Grace. Grace also is a, say, maternity bundle provider. Grace sees them, bills another E&M code with a trigger diagnosis that would switch the case over. If I see them, say that was September, we both see them in September. Grace saw them after I did, after I referred them. Both that month, we would both receive a case rate if it was in the same calendar month. However, that case rate would remain with Grace unless I see them in October and I bill another E&M with a trigger diagnosis, then it would revert back to me as the primary. So case rates for multiple providers under different TINs can be paid in the same month, especially if people are going back and forth in terms of seeing that member. If the MFM provider and the OB, if we were under the same TIN, we would receive in the case rate. It wouldn't change that. There wouldn't be an effect if we were under the same TIN. So hope that clarified a little bit. Grace, anything else you want to add to that?
No, that was super clear. Yep.
Great. The next question we have is, when will fee-for-service doula services become available?
The plan is to launch that ideally, we're shooting for a January 1 launch date to coincide with the launch of the maternity bundle. There will be an update on that once we have more certainty, but that is our plan as of now.
How is an MFM supposed to see a patient for a consult and send them back to their primary OB/GYN midwife without taking over the case rate?
Discuss that a little bit. So you could take over the case. So there's another option. So one is to make sure as you're billing, make sure you're not billing a trigger code and diagnosis together. So that is another way of doing it, being very prescriptive if you're planning on only providing consultative services. So in the example I provided before, where Grace is a MFM provider under a separate TIN, and I am a OB provider under a separate TIN. If I referred the member to Grace, Grace wasn't going to take over. In this case, was only providing a one-time consultation, could specifically bill in a way that avoids triggering a case rate. So that is another mechanism. It is also appropriate, though, for if Grace was if that was potentially, sometimes it's uncertain. Right. Sometimes we might not know who's going to have final ownership because there's additional testing, et cetera. Again, we've tried to build this in a way that both providers can receive the case rate essentially every month that is occurring. So especially for someone that's high risk that maybe is going back and forth between providers, that can occur. So if I saw them in September and in October, and I'm dropping a E&M code with a diagnosis code that would trigger it, and Grace is doing the same, we both in September and October could receive a case rate in both of those months, including moving forward, which could occur, and we've tried to structure it in that way.
Our next,
sorry, just want to make sure anything else, Grace or Tiffany, to clarify on that.
Nothing from me.
A question about doula and lactation services. Do you have to pay back doula and lactation service monthly fees if the patient does not utilize these services, but they are available to the patient within the practice?
Happy to take that stab first, and then Grace Tiffany can add anything else. But in terms of, so break them apart because it's important to separate them. How we structured this is for doula add-on payments. So that's again on top of the case rate that's being calculated. And we've also, just to know, have allowed practices to opt out of those payments. We did want to provide them upfront so to make sure there was cash flow opportunities for providers to be able to pay doulas in an upfront manner, as opposed to waiting for a reconciliation that can take over a year to pay out. But those dollars, specifically for doulas, are at risk. So if those dollars are not utilized, we will have a reconciliation. We've kind of estimated about a max 10% utilization so if you have 100 Medicaid members on your panel, we've built the rate in such a way that if 10 of them use a doula, you'll essentially be made whole. For those that use less than 10% utilization, approximately, again, this will be done on a utilization basis. So this is approximate. You will, if you use, again, less than that, you would be likely have money that's owed back to DSS. If you're utilizing more than 10%, there's additional dollars that would flow to you in the reconciliation process at the end. So just to say, that's specifically for the doula piece. For the lactation consultant, there is not a reconciliation for those dollars. We anticipate those dollars being utilized by the practice for enhanced lactation education and service provision for those that need it. But we will not be, there's not a current plan to do reconciliation based on that PMPM. Grace, anything you want to add or clarify that I said?
No, I think that was very accurate. I just want to specify the doula PMPM is $14 per month, just paid alongside with case rate, no matter what the actual utilization looks like. And as Dr. Rich just mentioned, we'll do a reconciliation at the end of the year. But lactation services is $7 PMPM, and those will not be reconciled.
Great, thank you. What is the reason for not using a more current data range to calculate the case rate, such as 2023 or 2024?
Yeah, so thanks for the question, Angela. So yeah, we arrange that time period because of internal data processing timeline and some runout we'll need in order to consider the claim data received are complete. So, when we initially designed it, it was sort of the latest and greatest 1 year we can use, assuming the launch date was 9/1/2024. But obviously now everything is pushed a little bit further, but we've processed everything. And since it's only a couple months, we still feel like this 10/1/22 to 9/30/23 time period is sufficient. And do keep in mind, so the delivery ends 9/30/2023, but the 90-day postpartum will actually end 3 months after that. So if you will, it's pretty much including all experiences in 2023.
Those are all the questions I see in the Q&A. If folks have any other questions, you're welcome to submit, or you can also go ahead and raise your hand and unmute yourself.
I did get a direct question. I'll just read it out loud. Tiffany, just to say it, does this maternity bundle include FQACs? If not, is there a future date that FQACs will be included? We have extensively discussed FQAC participation, and we actually did some outreach and engagement in this last 12-month period. There was some interest on the part of FQACs, but not overwhelmingly so in terms of interest in this. Because of the complexity of developing, you would think it'd be easy just to say, we'll turn this on for FQACs, but given the complexity of the FQAC payment structure, actually requires quite a bit of additional work, and there's some challenges with actually implementation in FQACs. And given the I would say some interest, but not a full-fledged interest across the board for FQACs, we haven't planned on launching it as of year one. We have said we will continue to look at launching it, and we are interested in doing such, acknowledging that it's going to take an extensive amount of work and time to do it in a way that makes sense across the board. Tiffany, anything else you want to add to that?
No, I think you covered it. A new question just came in regarding lactation services. Can lactation services still be billed fee-for-service outside of the bundle?
Would need some clarification. Currently, we don't, there's not enrolled. So for example, IBCLCs are not enrolled providers in Medicaid in Connecticut, and they're not able to bill specifically for lactation services at this time. There's been ongoing discussion about that with various stakeholders. But if you mean, could a provider bill for those services, maybe might need a little bit more clarification what provider type we're talking about. But just say it's a certified nurse midwife or a MD or DO that's providing those services, those would likely fall under the existing case rate because they would fall under your traditional E&M services that are being delivered. Just to add a little bit of clarity on that. Tiffany or Grace, anything you want to add or modify about what I just said? Any other questions? Folks are welcome to raise their hand. Definitely welcome other questions or comments at this time. I think
Brad,
we're
are we
good.
gonna post these Q&As on our site? Okay, great.
And I think the other thing, well, I think as if there's no other current questions or comments, I just want to reiterate that one is, we're delaying the launch. We definitely have heard some of the feedback. We appreciate the feedback, and we'll be looking to provide additional guidance on some of the specific questions that have been raised. Some of them are very helpful, and questions that hadn't come up before in terms of, especially some of the very technical questions that we want to make sure there's clarification on for all providers before we launch. And so we see this, and I'm sure many of you heard me say this before, but we see this as an iterative process. We really do want to make this successful across the board for providers, for DSS, for our members. And so we've tried to build this in a way that providers can ultimately feel comfortable with, acknowledging this is a significant deviation from historically what providers have done in terms of some of what they've been asked to do. We do hope that by providing more financial resources, and we do expect more dollars to go to providers through this bundle than previously have, will help providers be sustainable, provide additional wraparound services for members, and reduce outcomes, especially for those communities and individuals who've historically been marginalized and had worse outcomes over time. And so really, but we know this is a marathon and not a sprint. And so, we will be looking to partner and continue to work together as we get this off the ground to refine this program over time and make it better. So I think with that, we can likely close. Bill, anything else you wanted to share?
No, I appreciate your closing remarks. So I don't want to step on those. I want people to leave with those.
All right. Thanks, everyone. We'll make sure these are posted, and look forward to hearing from more of you in the future. Thanks.